Usually it may be difficult for a patient to know when he needs an EUS or ERCP, but a few common things, let's say when you have a difficult lump, when a doctor does a gastroscope, or you have a problem with your pancreas, your bile duct or your liver, or you got a problem in your plumbing, then that's when you know you may need an EUS or ERCP.
Hai, saya Ira dari Lavender Medicare. Hari ini saya akan menginterview Dr. Benjamin Yi. Dia adalah seorang ahli untuk endoskopi yang lebih kompleks. Thank you, Dr. Benjamin, for your time to do this interview with us. So today we want to discuss about the endoscopy, but the more advanced endoscopy.
Ultrasound endoscopy or endoscopy ultrasound or EUS is an endoscopy procedure that has got an ultrasound component as well. So you can do both. You can actually look at the surface of where you're going, for example, the stomach, and you can also look beneath the surface, at the deeper structures such as the pancreas or lymph nodes.
So when do we actually need to do this EUS?
So for instance, you do a gastroscopy for whatever reason and you find a lump, and but the surface of this lump or tumor looks the same as the surroundings. So this lump is from deeper, and you will really need the endoscopy ultrasound to see first of all, what does this lump consist of, which layer is it coming from, and also EUS allows us to put a biopsy needle through the working channel of the scope and obtain biopsy samples for diagnosis.
I see. So it's also for treatment purpose?
Mainly for diagnostic, but you're right. EUS is moving towards more therapeutic now. The first therapeutic indication would be for a cyst in the pancreas called a pseudocyst. These are usually in patients with very bad pancreatitis, and then EUS can be used to place a stent across the cyst and draining the cyst either into the stomach or the duodenum. And there are more advanced things now where, let's say you do an ERCP for a patient with a blocked bile duct, for example, in the head of pancreas tumors, and then you find that the duodenum or the small intestine not accessible because of the tumor, you can actually target a bile duct higher up, let's say into the stomach, from the EUS, and you can put a stent into the bile duct itself. So this is the therapeutic advances in
So
EUS.
it's considered safer rather than to do surgery and to go in?
Oh, definitely, yeah, definitely. Any endoscopic procedure is minimally invasive and will be safer than even laparoscopic or keyhole surgery.
But how effective is it?
It is very effective. For example, for pancreatic tumors, EUS guided biopsy is the most effective and accurate way of diagnosing these tumors, even more effective than what the radiologists do by sampling the pancreas from the skin. And sometimes it's not even possible because the pancreas is such a deep structure that the surrounding vessels, spine, other organs will make it impossible to sample certain areas of the pancreas.
Can we actually just use a normal ultrasound to do this?
A normal ultrasound is done from the patient's tummy, right, on the skin surface. So for the pancreas, for example, it will
Cannot reach, is it?
It can't reach because pancreas is very deep, and then it's behind bowel, and bowel is full of gas, and gas is the enemy of ultrasound, so you cannot see the pancreas. Whereas if you do an EUS, then the gas is out of the equation because you're in the bowel and you're actually right next to the pancreas. So I always tell my patients EUS is tailor-made for the pancreas, because if you look at the anatomy, and we'll show you pictures, every part of the pancreas can be reached via different parts of the digestive tract. For example, the top of the stomach, the end, the first part of the duodenum. It's just made for the pancreas.
How does this procedure is done? Do the patient need to be sedated?
The preparation is the same for gastroscopy. The patient will need to be fasted for 6 hours. If the patient is on blood thinning medications, the doctor may ask the patient to stop for a while, and the procedure usually takes a bit longer, about 45 minutes to an hour. So the anesthesia or the sedation may have to be a bit stronger. And by and large, it's the same recovery, and you may have to fast for 2 to 4 hours after that, and then you can resume your normal diet usually.
So is it dangerous to get some biopsy sample from the pancreas? Whether, sometimes we worry about the cancer will spread if you
Yes.
do biopsy and things like that.
Yes, that's a good question. So there's two answers. So the risk, mainly if you biopsy the pancreas, will be bleeding. It happens in less than 2%. And if you go through normal pancreas, the pancreas can get inflamed, you can get pancreatitis. Also happens in less than 2%. And you're saying the tumor spreading, that's seeding from the needle tract. Actually, it's been reported before, but very, very rare. So it'll be much less than, say, 0.1% or 1 in 1,000, much less than that.
So what's the difference between ERCP and EUS?
So ERCP also stands for endoscopic retrograde cholangiopancreatography. It's a mouthful, but as the name suggests, it's a different entity altogether. It's also an advanced endoscopy procedure, but used to target problems in the bile duct, which is the C part, cholangio, and to target the pancreas duct, which is the P part, the pancreatic duct. ERCP is a direct endoscopy procedure. There's no ultrasound component, and it's only for diseases in these two tracts. So the can be divided into benign and malignant or cancerous problems. So for instance, the bile duct, the most common problem we deal with would be common bile duct stones. So for patients with gallbladder stones, sometimes the stones spill out into the common bile duct and cause pain, jaundice or fever. And then ERCP is being used to remove the stones from the bottom of the bile duct. We will show pictures again. And there are many instruments which can be passed through this ERCP scope. And it's got a very big channel, the biggest channel in any endoscope. And then we can use a variety of instruments to help us to remove the stone. So the second thing would be blockages, would be what we call strictures in the bile duct on the pancreas. And then they can be malignant or benign. And again, instruments can be passed through to either diagnose the nature of the stricture and to stent the stricture so that the bile duct or the pancreas duct is not blocked. Yeah?
So after ERCP, how does the patient will feel like?
So the patient will not feel the stent most of the time unless the stent slips out of position and then presses against the small intestine wall, and the patient may feel pain. So in that case, we have to go and revise the stent. But this procedure is any usual endoscopic procedure. It is minimally invasive and it's fairly safe as well.
Once the stent is put in, if there's any blockage, it's permanent?
Yeah, so there are two main types of stents. The plastic stents are not permanent. They're meant to only last about 3 or 4 months. We have metal stents as well, and these are considered permanent, but there are types of the metal stent which can be removed as well, the fully covered ones. So for patients, usually we use these metal stents for cancer patients. So they're meant to be there as a palliative procedure to help improve the quality of life.
Dr. Benjamin, thank you so much for the information. So last questions. What is your advice for patient who needs to do EUS and ERCP?
A few common things, let's say when you have a difficult lump, when a doctor does a gastroscope, or you have a problem with your pancreas, your bile duct or your liver, or you got a problem in your plumbing, so in your bile duct or your pancreatic duct, then that's when you know you may need a EUS or ERCP.